Christian Matus Regules, Nicole Finkelstein, and that's it. So the background is on, there's a poster on HIV in a Mexican state of Oaxaca, where it is the state with the largest indigenous population in Mexico. Mexico is the country that has the largest indigenous population in the Americas. So even though this is a situation in Mexico, different from the US, in Mexico it is not health data is not segregated by ethnicity the way it is here in the US. And particularly in the case of HIV, this is a big issue because as I'm going to show you, there's big inequalities regarding indigenous indigeneity in terms of HIV. So what we did was going over a database that was started by its Healthcare Foundation, its Mexican chapter, AHF Mexico, that did record did register indigenous status in the HIV database in a particular clinic called Capacits in Oaxaca City. This clinic cares for 82.2% of the people living with HIV in the whole state of Oaxaca. And it is a state that has really poor infrastructure in terms of roads. So it is very hard for a lot of people who need to get care at this clinic to get into this clinic. So what we did is, using this database that had registers from a 24-year period, and it had different viral loads. The most it had for particular subjects was 11 measures of viral loads. So we worked with averages, and we used a pair t-test, and we analyzed the mean differences of the first and last viral loads in this 24 period from 1995 to 2019. Also, we carried out semi-structured interviews to patients of a mobile clinic that took care of all these patients that were in a very far distance from the Capacits in the main city of Oaxaca State, and also participant observation at this mobile clinic. Then, if you can see the graphs here in the results. So there are 2,400 patients at the Capacits clinic, the central clinic, and 1,571 patients that are taken care by the mobile clinic implemented by AHF Mexico. And these are the ones precisely that are actually segregated in indigenous and non-indigenous. So as we see here, the average patient in this 1,571 patients that are segregated started with a viral load of around 27,000 and finished with a viral load of 14,000 copies of the virus. So this was a reduction of 48%. However, when these are stratified by indigenous status and non-indigenous status, we see that in the average in the indigenous group of reduction of decrease in viral load was 36%, while in the patients that were not categorized as indigenous, it was 50%. And in the qualitative part, when we interviewed mainly indigenous informants, most of them said that the main barriers that they faced while trying to go to Capacits, which is the main clinic that takes care of HIV patients living with HIV, were transportation fees, that most of the population live with $1 a day, and the transportation fees exceed this quantity. Also discrimination in terms of language discrimination, because many of them do not speak Spanish, which is a language in which healthcare providers communicate with most of the patients. And also with really lack of infrastructure, both for diagnosis and care in their own communities. So this project is mainly a first approach to a lack of information that there exists in Mexico in terms of the health status, the health conditions of indigenous population. That is, of course, it is detrimental to the betterment of their conditions. So I hope we hope this project is able to promote further engagements in this topic.
All right, thank you. If you have a question, you can put it in the chat. I think we have time for one question, and I can ask one. I don't know if anybody wants to unmute. You said that it's not typical to record the data on ethnicity in Mexico. How did you get that information for this population? Did you ask them, or?
Yeah, so in this, the way that in Mexico works is mostly they ask if you speak an indigenous language. So in this, since AHF Mexico partnered with Capacit, which is a government clinic, they were able to have their own databases. They were allowed to, and the patients that were taken care by AHF Mexico in the mobile clinic, in the mobile clinic, they were asked if they spoke an indigenous language and if they consider themselves indigenous. Of note, the database was not made by us, by Alma or by myself. It was recorded by it was made by the healthcare providers in AHF Mexico, in the mobile clinic.
That's interesting. It's very different from the US. Anthony has a question. Do you want to ask it, Anthony?
Yeah, sure. Thank you for that presentation. I was just wondering, how was ethnic discrimination measured?
Yeah, so this is the part that is not measured. This is data collected through semi-structured interviews and also observation. That it would be interesting to have further work on how to measure this discrimination, but at least all of this was provided by the qualitative side of the project.
All right, thank you. I think we will move on to the next presentation. We'll have time at the end to talk about all of them, I think, if we move through these. So Maria Bazan, we'll talk about HIV and incarceration on a literature review that she's done. Maria?
Good morning.
Oh, there you are. Thank you.
Yep. So I wrote this literature review to investigate whether incarceration in the US poses any medical or social consequences for men living with HIV and how incarceration affected their immunological and viral outcomes. So I can start with some background on the demographics and risk behaviors associated with HIV. So as we know, not everyone is equally affected. Lack of employment opportunities, discrimination, and mass incarceration creates a low socioeconomic status that disproportionately affects certain groups and contributes to the increased vulnerability of HIV acquisition. These factors include insecure housing, financial instability, lower education levels, and lack of access to quality healthcare. And they serve as stressors and obstacles that override or prevent prioritizing patients' health and are linked to inconsistent involvement in HIV care. And then other factors include drug convictions and limited access to healthcare that enable HIV to be left untreated. So now that we've identified some risk behaviors and the basis for their existence, we can talk about highly affected populations, since certain groups are subjected to these realities a higher proportion than others. And these groups are African American and Latino men, those with mental conditions, transgender people, and men who have sex with men. And universally reported challenges among these groups at higher risk of acquiring HIV include stigma, homophobia, and discrimination that increase stress, limit social support, and negatively impact overall well-being because of limited access to quality care. And then overlaps between the demographics of groups vulnerable to HIV and the prison population are elevated risk and poor social conditions, given that 1 in 5 men living with HIV pass through correctional facilities each year, which motivated the reason behind this literature review. So our results detailed like the social and systematic barriers men living with HIV encountered during incarceration, the consequences they experienced once released, and the overall harmful effect a conviction had on their well-being. So during incarceration, certain barriers made HIV care inaccessible, and these systematic factors introduced influence as soon as inmates were arrested, seeing as certain medications were confiscated or not on their persons when detained. And other factors included mistrust in the prison healthcare system and reported poor medical care, including lack of communication that deterred inmates from participating in treatment. And then another reported factor was fear around accidental HIV status disclosure, which contributed to stigma and to the foregoing of treatment to avoid rejection and discrimination from others. And as far as viral and immunological outcomes while incarcerated, improved outcomes in HIV positive inmates were reported by 2 retrospective cohort studies. And their studies found that overall CD4 counts and lower viral loads increased in the majority of their study population. However, it should be noted that results were due in large part to the resources available in prison that aren't as accessible to most inmates while in their communities. Since penal institutions are required to provide medical care to prisoners, which creates a stable, structured environment and steady access to medications that enable inmates to partake in HIV treatment for the first time for most of them. And then other studies concluded the opposite trend. So a study done at Harris County Correctional Facility in Texas found that the stressful environment and overcrowding in prisons resulted in disproportionate decrease in inmates' CD4 counts compared to the CD4 counts of an outpatient population. And then overall, 5 peer-reviewed studies concluded that most immunological and viral benefits obtained while incarcerated were short-lived due to the lack of access to healthcare, engagement in high-risk behaviors, and other stressors that made it difficult to access and prioritize HIV treatment once released. And then those are the obstacles faced while incarcerated, and then obstacles faced after incarceration includes subpar release planning. So proper release planning is an effective mechanism to connect inmates to outside resources recommended by not only prison faculty, but also community-based organizations, recently released prisoners, and the CDC. But despite these recommendations, one study that surveyed more than 43 state prisons found that only 8 followed the CDC's guidance on discharge planning. And in addition to state prisons not following recommendations, right, as of now, there is no common system in place to regulate discharge services. So miscommunication between prison staff and community groups is also an issue that varied across correctional facilities. And lack of communication between services serve as a deterrent in ensuring inmates are enrolled in programs such as Medicaid by the end of their sentence, which is basically releasing inmates with the absence of essential resources. Another barrier they faced after being released was housing instabilities and revoked benefits. So certain convictions disqualify released inmates from food stamps, public housing, driver's license, student loans, and in 14 states voting, making it more difficult to access and prioritize your health care for recently released prisoners once released. And then other factors included lower educational levels, unemployment, financial status, comorbid conditions such as mental health conditions and substance use, seeing as continuation of care is difficult to maintain once released due to pre-existing comorbid conditions faced by a substantial amount of inmates, and the lack of treatment received while incarcerated. So all these factors compound and basically lead to high rates of prison recidivism. And it's unsurprising that the prison recidivism rates are so high, given all the barriers this population encounters when released. So according to a 9-year follow-up by the Bureau of Justice on more than 400,000 state prisoners, an estimated of 68% of released prisoners are arrested within 3 years and 83% within 9 years. And these high recidivism rates are detrimental for those living with HIV, since certain retrospective studies have found that CD4 counts decrease and viral loads increase in those who are incarcerated. So overall, while the medical consequences during incarceration vary, the results post-release reveal that structural factors compound and act as barriers to accessing and prioritizing healthcare for recently released prisoners living with HIV. And the few health progress made while incarcerated isn't maintained and worsens once released due to the lack of employment opportunities, housing instability, ineligibility from public assistance, revoked rights, and poor release planning correctional facilities offer. And these factors limit opportunities for inmates to succeed in society and lead to the high rates of recidivism that are linked to increased viral load and lower CD4 counts. So overall, having a higher history of incarceration amplifies socioeconomic inequalities that groups at higher risk of acquiring HIV are already predisposed to. And since the image I showed on my presentation slide, these studies regarding the barriers presented by incarceration are limited and dated, with 9 of the sources being not being published within the last decade. So I recommend further research on how incarceration affects people living with HIV to improve the socioeconomic status and well-being of this population. And I also recommend that this research implement an intersectional approach, seeing as incarceration enforces the poor socioeconomic status. Those poor socioeconomic conditions people at higher risk of HIV are already subjected to.
All right, thank you. We have time for one question. Well, I did find that pretty interesting that, I mean, I assume you did say it varies by state, but that you can get better healthcare, so that people can get better healthcare in prison as opposed to out of prison, and that speaks to perhaps changes that should be made for people who are living outside of, who are not incarcerated. I don't know if you had a thought about that. You're on mute, Maria.
Oh, sorry. Yeah, that was a finding that I was definitely shocked by. And a lot of the authors in their papers wrote that for them it was unsurprising, seeing as these groups are already predisposed to a lot of socioeconomic barriers. So it makes sense that because correctional facilities are required to give healthcare treatment and healthcare access, that these groups have access to medical care for the first time. And that's what leads to their short-lived better health outcomes while incarcerated.
Right. Apparently this is a plot line in the show Shameless. Now you have made me want to watch that. That family is a little bit okay, yeah. I just think it's, in terms of a structural barrier for people to be healthy who have less access to healthcare, it's seems like that's a lesson that we could be useful for, again, to talk to policymakers about. So thank you, Erica and Maria. And we are going to go to our next speaker, who's Monica Stretten, who I think I pronounced your last name right. but you can correct me, please. Identifying bias against Black pregnant patients among prenatal providers. Monica?
Hi, good morning. My name is Monica Stretten. I'm a fourth-year medical student at UCSF, and I worked on this project with Johnny Curlin and Dr. Andrea Jackson from the Department of OBGYN to identify potential bias against Black pregnant patients among prenatal providers. So our project was conducted with the recognition of significant disparities among in birthing outcomes experienced by members of the Black community. Notably, Black birthing people are 3 to 4 times as likely to die from pregnancy-related complications as compared to their white counterparts. And also notably, Black infants have the highest mortality rate compared to infants of all other races and ethnicities. We also understand the potential role of provider attitudes that can contribute to these disparities. So we understand that the current literature demonstrates differences in reported physician trust in patients by patient race or perceived patient race and ethnicity. Several studies have shown lower confidence ratings by providers attributed to their Black patients. In addition, there are many studies that have found that patient avoidance of seeking prenatal care is correlated with prior experiences of racism within the healthcare system specifically. So given all this, we sought to investigate whether prenatal provider trust in patients varied by patient race and ethnicity, with the specific intention to examine for potential bias against Black pregnant patients. So our study relied on an IRB-approved anonymous voluntary survey that was sent to the Department of OBGYN in October of 2017. Of those who chose to respond, 50% were OBGYN residents. The rest were attending generalist OBGYNs, attending maternal fetal medicine specialists, and attending nurse midwives. The vast majority of respondents self-identified as cis women, and nearly 63% of respondents self-identified as white. The remaining respondents were Black. 18% of respondents were Black, and 18% reported self-reported other ethnicities and races. The notable portions of our survey assessed provider confidence in patient behaviors and attributes on the Likert scale, with responses ranging from not at all confident to completely confident in response to several statements. So the questions asked, how confident are you that your prenatal patients will, some examples include keep their appointments, follow treatment recommendations, be actively engaged in their care, and others. And so these questions were asked first about providers, about all pregnant patients, and then asked again specifically with regards to Black prenatal patients. And the Likert scale responses were summed with higher scores indicating greater confidence. And the total possible scores were 48 points. And that would only be summed, that 48 points would only be if somebody said they had the most confidence in every single aspect. The data were then analyzed with t-tests, chi-square tests, and ANOVA INS data. The results of our responses were quite interesting. There was a small difference noted in total confidence in patients determined by perceived patient race. To clarify, that means that providers overall reported a confidence of 27.6 out of 48 in white patients with a standard deviation of 21.55, compared to a total reported confidence of 26.2 in Black patients with a larger standard deviation of 23.28. And when we considered these responses specific to confidence in Black patients, there were statistically significant differences in reported values by white providers compared to non-white providers. So compared to non-white providers, white providers reported lower confidence in Black patients, in Black patients' ability to keep their appointments, as well as their ability to follow recommended treatment plans. And both of those were calculated with p-values of 0.029 and 0.006 respectively. And those were the main statistically significant findings of the survey. I think there were also some free response portions of this survey that allowed us to kind of get a sense of other attitudes that folks had towards their patients and kind of understanding their underlying thought processes, I think, when they approach clinical care. But bringing this all together, we did find that prenatal providers reported lower rates of confidence in Black patients compared to all other patients, which does raise concern for bias against Black prenatal patients within our institution. And these disparities may be mediated by providers' self-reported race, as evidenced by white providers reporting lower confidence in Black patients compared to non-white providers. So I think moving forward, we would really love to have further research to examine the impact of racially concordant care as a partial solution to disparities in provider attitudes, which may mediate birthing outcomes and potentially improving birthing outcomes. This study also underscores the need for more initiatives to promote justice, diversity, equity, and cultural humility within obstetric care, which we hope to move forward to study in the coming future. And that's all. Thank you for listening.
All right, thank you. The questions for Monica? Were the providers at Mission Bay, or were they the San Francisco General? You're on mute, Monica.
Thank you. This was primarily providers for Mission Bay, but the residents cover both hospitals.
Mm-hmm. Do you have a comment on the fact that you don't have, let's see, I guess it's more trainees here than?
Yeah, it was about 50% of respondents were residents.
I have a question, if we have time.
Yes, of course. Sorry, I didn't see your hand.
Okay, you may have mentioned this. What was the non-response rate? Seems 28. I don't know how big the division is, but 28 seems not big. But
it's pretty low. So we actually had the original response rate, or not rate, but the N is 28 here reported, but we actually had an N of 54. However, not everyone responded to all questions, and so the N of 28 is just the number of people that we were actually able to analyze their responses compared to their demographic information responses. But it is, there are many more than 28 people in the department.
And I guess the question, do you think that your findings would be different if you had more responses?
Yeah, I think that's a really good question, and that this was a big limitation of our study, given how few respondents that we had. I think that it's hard to speculate. My best guess is that the responses wouldn't change very much, but I would have to get more data to really definitively tell you that.
Well, it's interesting. Do you ask them about all patients, or do you ask them about specific kinds of patients? Because maybe people will be biased in how they respond because they don't want to be perceived as biased.
Yeah, so the first set of the questions were the same, in terms of like, what is your confidence that they'll keep their appointments, keep their, et cetera, all the things. But it was specifically asking, how confident are you that your prenatal patients will blank? And then the follow-up was, how confident are you that your Black prenatal patients will blank? So I think there was some, up to the respondents, the respondents could have understood this in whatever
yeah
way.
Well,
Yeah.
I think that is, yes, maybe think about a different way to ask it. So, because people could respond with how they perceive you want them to respond.
Mm-hmm, definitely.
Yeah. Very interesting. Any more questions? All right. Thank you, Monica. Sorry, Monica. Sorry, I was looking at the wrong slide.
Thank you.
There. Thank you, Monica. And now we have Bora Nam, who will be presenting on behalf of Vanta Park. Correct my pronunciations, please. That was incorrect. That was incorrect.
Hello, everyone. I'm here to present on behalf of Dr. Van Park, a PI of this study. She was unable to present today due to the family emergency. The title of the poster I'll present today is COVID-19 related discrimination experiences among Asian Americans and Pacific Islanders the COMPASS study. Since the COVID-19 pandemic, the hate crimes against Asian Americans and Pacific Islanders, as known as AAPI, have dramatically increased, making this a public health priority. So we examined the proportion of and the factors associated with COVID-related discrimination experiences due to being AAPI using the data from community-based national survey called COMPASS, COVID-19 Effects on the Mental and Physical Health of AAPI Survey Study. This study reports on the 4971 participants who complete the COMPASS survey from October 2020 to February 2021. Eligible participants self-identified as AAPI, able to read one of the languages provided, English, Chinese, Korean, Samoan, or Vietnamese, aged 18 years and older, and resided in the US. It is a one-time online survey, and the mean survey completion time was 21 minutes. Perceived discrimination experience during the last 6 months during COVID-19 pandemic was assessed by using a revised 8 items everyday discrimination scale, EDS. Like previous research, we dichotomized any discrimination experience as yes or no. Participants who responded never to all items were categorized as having no discrimination experience, and those who experienced any discrimination to any of the EDS items were categorized as having a discrimination experience. We examined the odds of experiencing discrimination using multivariable logistic regression. And this is the result. Mean age was 45 years, ranged from 18 to 97. 2/3 were female. The major cultural groups included ethnic Chinese, including person from China, Hong Kong, and Taiwan, followed by Korean and Vietnamese. 63% born outside of the United States. Majority of participants were from California. 22% had limited English proficiency. Overall, 61% of participants reported discrimination experience because of being AAPI. Figure 1 shows the proportion by each EDS item. 52% had experience on the item. You have been treated with less respect than other people because you are AAPI. 38% answered because you are AAPI, you've been treated with less respect than other people. The table 1 shows varying prevalence by cultural groups. Compared to Asian Indian, Hmong has the highest prevalence of discrimination experience, followed by Chinese, Korean, Filipino, Japanese, and Vietnamese. They also reported higher prevalence of discrimination experiences compared to Asian Indian. Multivariable models revealed COVID-19 related experiences were associated with discrimination. Being Asian American and participants who are female, younger, living in the non-West regions of the United States, and those with poor health were associated with greater odds of discrimination experiences. Also, having a shelter in place over more than 1 month, living in the areas with higher COVID severity, more severe effect on COVID-19 on family income and employment were significantly more likely to report experiences of everyday discrimination. So the conclusions. This paper presents one of the first national studies that examined the prevalence of and factors associated with discrimination experience due to being AAPI during the COVID pandemic. Overall, alarming proportion of participants reported discrimination experiences. Also, this study identifies some groups being more vulnerable than others in experiencing racial discrimination, in addition to variation in API subgroups. Discrimination is a public health priority for API, and we hope that our findings will pave the way to alleviating discrimination against API. This presentation was supported by the National Institute on Aging of the NIH, and we want to thank you to the participants who complete the COMPASS survey and our community partners for their strong support. Thank you.
All right, thank you. We are, that's very interesting. Does people have any questions? I was wondering if you could talk about where people, the geographic locations of the respondents.
Most of them are from California, because this study was like collaboration between UC Davis and UCSF. But we also have some Hawaiian populations, and some of them are from East Coast and southern part, but they're like under 20%. Most of them are from like Western Coast. It's over 80%.
Thank you. I had a question. Is this the 67% as if you answered any one of these questions?
That's correct.
I see. So some people had different experiences than others. Is that my
Yes.
interpretation of this? Yeah.
Mhm.
Okay. Okay. Are there other questions from Bora? Can you say what did you say the COMPASS study is specifically for
API.
But is there
Asia.
going to be other components to the study besides in addition to the questions about discrimination and racism?
Yes, we already published 2 papers about the vaccine willingness and like vaccine concerns, and others are coming. And this study is under review, so we just focus on the descriptive findings today. And we want to announce that we just got funded for the COMPASS 2 study. So we are planning to follow with the COMPASS participants to examine the long-term effect of COVID for API.
Mm-hmm. Are you guys looking? Oh, that's great. Put some information about the COMPASS study in the chat. Well, thank you. Any other questions from our participants? Or about any of the other presentations? I thought they were all interesting and covered different aspects. And just to remind everyone, the topic area that we're in is racism and structural barriers. I don't know if anyone had any of our presenters had any thoughts about structural interventions that could be pursued to address the topic areas that they were covering. I know we have 10 minutes before the keynote. Yes, Bernardo.
Well, I guess that particularly in the context where our work was done, I think that something that we're calling for is more data on the populations that we are that are mostly subjected to these structural barriers, because without this data, there's nothing that can be done. And particularly in HIV, where there's really good markers for success in the treatment, it is basically like a shame that we don't have as in a public register information about this. So I think that the first step would have to be having segregated information.
And do you think that countries like Mexico should collect their data similar to how we do it in the United States? So the United States could upgrade how they're collecting race and ethnicity information. It's interesting because I was just looking at this issue because we've been looking at it for populations, and OMB was going to change questions on the census, but that didn't happen. So I don't know what your thoughts are.
I think this is this is like an ambivalent topic because categories also can work as devices for discrimination. So these have to be taken like very, very carefully. So I wouldn't think that at least Mexico would have to follow like a US model, but it would have to be some sort of categories or some sort of way to collect all this data that obeys or follows the particularities of the Mexican context, where race and ethnicity work in a different way than they work in the US or in any other place. So yeah, I also guess that the US would also have to work a bit more on how they do this categorizations in terms of ethnicity and race, for sure.
Right, and there might be opportunities for that to change during this next several years.
Sure.
Anybody else have any thoughts, comments? Oh, you put me on that screen thing that's like, Melissa, do you want to announce the exciting keynote? Oh, I'm sorry, Bernardo, did you want to say something else?
Yes, thanks so much just to all the presenters and for you all for showing up today. Just to kind of
I have a question for you, Melissa. Maybe you can tell us what the Multicultural Resource Center is. That would be very useful. I would like to know that.
Yeah, definitely. I'll share a little bit more about the MRC after, but just kind of reminder that we do have our closing keynote with Dr. Kamara Phyllis-Jones from 11 to 11:45. So I did pop it in the chat, the link where you can register so you can join. So again, I serve as Assistant Director for the Multicultural Resource Center, part of the Office of Diversity and Outreach, and I get to be able to support Tracy here and support all of our presenters today. A lot of the work that we do for the Multicultural Resource Center is to support our learners, specifically our learners that come from historically excluded yet resilient backgrounds and communities. We do a lot of work around providing interprofessional spaces for students and learners across all the professional schools, as well as graduate division, to be able to come in community and also learn about social justice frameworks that will guide our students as they emerge in their leadership and also as healthcare professionals. Thank you.
Excellent. Are you on the UCSF website so we can find you?
Yes, you can go to mrc.ucsf. I'll just go ahead and send that here. UCSF.edu. We are also very active on Twitter. So if you are connected to Twitter, you can go ahead and follow us at UCSF_MRC. And more than happy to have a chat and connect with any folks that are interested in learning more about what we offer.
That's excellent. Well, I'm definitely going to follow you on Twitter. We can all follow each other. People do that kind of thing. So thank you, everyone. And thank you for the excellent presentations. They were super eye-opening. And we will let everyone get on to the next Zoom for the keynote address with Dr. Kamara Phyllis. Thank you, Melissa.